Hi everyone, this is Boris Farhang, and I'm going to talk to you about the pharmacology of local anesthetics. And I'm an anesthesiologist, so I get to use these local anesthetics in a variety of settings, be it in the local infiltration for numbness under skin, spinal, epidural, or peripheral nerve blocks, or even IV administration. So the first set of objectives we're going to cover is to look at the structure of local anesthetics and explain based on the structure what are the clinical use for, and also describe the differences between the ester and amide local anesthetics. Now, some backgrounds. Local and regional anesthesia, local like infiltration in skin to close a wound, or regional anesthesia, your peripheral nerve blocks or spinals, depend on a group of medication called local anesthetics, and they temporarily inhibit nerve function. Local anesthesia is defined as a loss of sensation in a discrete region of the body caused by disruption of impulse generation or propagation. Local anesthesia can be produced by various chemical and physical means like cryoanesthesia, ischemia, etc. But really, in clinical practice, when we talk about local anesthesia, we're talking about local anesthetics. Now, some history. The use of chemical substances to prevent or treat local pain had its origin in South America, and native Peruvians used coca plants for its CNS stimulating effects, but also noticed as a side effect some circumoral numbness. In 1860, Niemann was able to isolate the active ingredient from these leaves, which was an alkaloid named cocaine. But it wasn't until 24 years later that its clinical utility was discovered when Kohler started using it as a topical agent for eye surgery. Cocaine was a benzoic acid ester, so this paved the way for development of many similar compounds that be used in current clinical practice today. Here you can see the chemical structure of cocaine on top and the base map of local anesthetics in the bottom. You can see the lipophilic side of the local anesthetic here that contains the aromatic ring. And this is the hydrophilic end that is bound to the hydrocarbon chain. In 1905, procaine, as you can see in the diagram on the right, was synthesized. It was the first useful injectable local anesthetic and became the prototype for the future of local anesthetics. It was derived from an aromatic acid called PABO or paraminobenzoic acid, and also an amino alcohol to result in a structure with the same three distinct regions of the aromatic head attached to a hydrocarbon chain through an ester linkage and a terminal amine tail. Tetracaine was the next ester that is still in use, and it was discovered in 1930. 1943 was kind of a breakthrough year because lidocaine was synthesized. And it's a breakthrough because lidocaine is not an ester, but it's an amide derivative of diethyl aminoacetic acid. As I already mentioned, local anesthetics agents have the chemical arrangement of aromatic portion, intermediate change, amine or ester portion. Amides compared to esters are more stable and have less chance of causing an allergic reaction. Changes in the aromatic or the amine portion of the local anesthetics alter its lipid solubility or lipid water distribution coefficient, as well as its protein binding characteristic, which in turn will markedly alter the anesthetic profile, like onset, duration of action, etc. Again, take a note of the lipophilic aromatic ring here. And in procaine and tetracaine, you can see the ester bond, but in the bottom, but lidocaine, now we have an amide. And note the hydrophilic terminal amines. Ester local anesthetics, as I mentioned previously, are derived from paraminobenzoic acid. The amide local anesthetics are derived from xylitine, including lidocaine, mepivacaine, bupivacaine, ropivacaine, or even levobupivacaine. Now, in contrast to lidocaine, the terminal amino portion of this newer compound is contained within a piperidine ring. Ropivacaine and levobupivacaine are the newest local anesthetics and share an additional distinctive characteristic. They're both single enantiomers rather than being a racemic mixture like the rest of them. The differential stereoselectivity of the neuronal and cardiac sodium ion channels can reduce the potential for the cardiac toxicity. And because they're amides, all of the new local anesthetic require biotransformation in the liver rather than undergoing ester hydrolysis in plasma, as is the case for the amino esters. Here you can see the piperidine-derived lipophilic portion of bupivacaine, and it's connected through an amide linkage to the hydrophilic side chain. And here's the diagram of the two historical esters on top, the cocaine and procaine, and the two commonly used amide local anesthetics, the lidocaine and bupivacaine, for your review.